other places for too long now.
Good morning, everybody. Welcome to the Healthcare Landscape Podcast. This is Dr. Avinash Jaiswal. I am health executive based in New York. I'm double board certified in emergency medicine and in general internal medicine. And this is a conversation about a series of videos and podcasts that explores healthcare from the lens of practitioners to take a close look at how their struggles are being overlooked from a regulatory standpoint and from a technology standpoint. I'm joined today by Dr. Lloyd Marks, and it's a pleasure to have him. Dr. Marks, thank you for joining me.
Thank you for inviting me.
Absolutely. Let us dive straight into introducing Dr. Marks. Dr. Marks is a trained pediatric cardiologist, and he was trained at Johns Hopkins. He's also an engineer from MIT. That's something we share, actually, Dr. Marks. I went to MIT too.
Oh, really? Okay, great.
On the management side.
So you're Sloan School?
Sloan School, yes.
Okay, excellent. I was course 6.
And so he has a lot of clinical experience, of course, in the pediatric cardiology area, having worked initially at Stony Brook, at Temple University, and at New Jersey Children's Hospital before running his own practice. And Dr. Marks is also at the interface of what is engineering and medicine. He has had venture startups with companies and has something like 22 patents on medical devices. So that actually is something he will talk about. I told him he should actually mention about that experience. And he does consulting now with his experience, having now stopped practicing. He is now consulting academic institutions, medical inventors, investors, efficacy groups, other people wanting to go to market, licensing, working also with the New Jersey Department of Health, developing business plans and financial projections. So this is, I would say, a very brief introduction for what is a very accomplished peer physician, may I say, a very inspiring story. I think, we met and we actually share the fact that I live now where he used to live. He used to live in Long Island, and now I live over here, and he moved over the other side of the city to New Jersey. So that was very nice to have him on the show. So let me just shoot your question, and then please go ahead by introducing yourself. So can you tell us about your background and how you became interested in this intersection of engineering and cardiology?
Sure. So as you mentioned, I got my electrical engineering degree at MIT, and when I graduated, I had an NSF fellowship. I was on a path to become an academic engineer, but I was intrigued by the idea of using engineering in medicine, and I had a cousin who was an innovator. He actually invented the field of anesthesia. Biotechnology. He was on the cover of Life magazine. He had transplanted one monkey's brain onto another. It was crazy stuff. But anyway, I went out to visit him in Pittsburgh, and I got intrigued by using my engineering in medicine. So I thought I would take it easy for 4 years instead of doing all the difficult work an engineer has to do. I figured I would just become a doctor. So, becoming a doctor is sort of flashcards. So I saw that as a vacation.
It is flashcards.
And I never intended actually to practice medicine, but I fell in love with pediatrics. I really loved working with the children. So I did an internship at UC San Diego in pediatrics and a residency at what was then called DC Children's Hospital, now called National Hospital Medical Center. And then after that, I did a brief stint doing some clinical research for infectious disease, and then I did a fellowship, as you mentioned, at Johns Hopkins in pediatric cardiology, and that I chose that because I wanted to be in an area where technology and medicine work together. And I became very interested in interventional cardiology. I had the good fortune of being at Hopkins when interventional cardiology for pediatrics was first done. In fact, I was in the cath lab when the first pulmonary valve was dilated and when the first coarctation was dilated. And I got all kinds of stories with that. But anyway, during my first half of my clinical career, I was in academic medicine, as you mentioned, Stony Brook, then at St. Christopher's Hospital for Children, where I was director of the cath lab. And then I was recruited to become chief of pediatric cardiology at the Children's Hospital in New Jersey. During all that time, I always had dual appointments in engineering departments, and I was developing various devices and inventions. As you mentioned, I had 22 medical device patents, and some of them have been successfully licensed and have generated some income for me. I've always been very, very interested in the intersection of engineering and medicine because it's kind of like it's kind of like two countries that don't communicate because they speak different languages, and I can bridge that gap and help doctors understand what engineering can do for them, and help engineers understand what the problems are that doctors have that they can potentially solve for them. And that's my story basically. I mentioned to you earlier that after I stopped practicing medicine, I got an MBA out of the University of Tennessee, and all of this directed at helping me run my startup company, which is called MGI Medical. We were commercializing a device that I developed for early detection of postoperative bleeding by looking at changes in peripheral blood flow. And I went to business school so I could become a better businessman for that company, and it worked. It allowed me to learn how to write a proper business plan and do financial projections. I love finance, things like that. And that's kind of my story. Right now, I do consulting, as you mentioned, consulting for academic institutions, for inventors, investors, and corporations that are trying to bring new technology to market. I'm particularly interested in developing the best form factor for devices so they're most effectively used, and also determining if there's commercially viability. So typically someone will describe a new device to me, and then I'll talk to the various doctors in my circle and determine whether there really is a market for the device. So that's what I do.
Awesome. That's like an amazing career. I really I'm very impressed. Tell me a little bit, what were some of the, being more general here, what were some of the most important advancements you've seen in the field and how they've impacted patient care?
Absolutely. So in my field, that's easy to answer. Interventional cardiology was the major advancement that I experienced. Just the timing was perfect because I was trained in it. So when I went to Stony Brook, I actually, the great institutions in New York would deny this, but the first interventional procedures in the New York metropolitan area were performed by me at Stony Brook. In fact, just a little aside, my boss,
Long Island.
Yeah, he had been working alone at Stony Brook for years. And when I arrived, he disappeared. He went on vacation. And I was alone. And sure enough, I had a critical pulmonary stenosis show up. So I was terrified, of course. I was in my first job as a clinician. So I called up my mentor at Hopkins, and I had her on the phone the whole time I did the balloon. But it was very, very gratifying because the baby came in blue and he left pink. So...
Wow.
And I'll tell you something else. One of the other patients I did at Stony Brook tracked me down last year. He found me and he wanted to tell me his story. And it was a beautiful story. He said that when I did the procedure on him, he couldn't do sport. He couldn't keep up with other kids because the pulmonary stenosis limited his cardiac output.
Of course.
And he said after that procedure, he said he became obsessed with sports. I'm not sure if he was a college football player. And now as an adult, he runs youth leagues in sports.
Oh, wow.
That really made me feel terrific.
Of course. I guess, sometimes, it's like a very athletic individual that has one issue. If you're able to fix that, it just opens up. Yeah.
Yes. Yeah. So, and this field continues to develop. Now they have we created a whole bunch of patients who have right heart failure, like tetralogy Fallot patients, and we would open their pulmonary valve, but they'd have really severe pulmonary insufficiency. Now we can put pulmonary valves in. So there's a whole bunch of adults now who are getting pulmonary valves in to save their right heart. So it's a wonderful field, interventional cardiology. And in fact, I invented a device for closing atrial septal defects using a nitinol, which is a shape memory alloy. And that device ended up resulting in there were two companies, Amplatzer and Gore-Tex, that used the technology, and they ended up paying me money because they infringed on my patents. But I ended up making a lot of money on the ASD closure device. That's my biggest success story.
Oh, I see. ASD. Oh, wow, interesting.
Yeah, so it's basically, it goes in as a straight wire, and then when it hits a transition temperature, it turns into two discs, which then close the hole.
Close the hole. I see. Okay. Yeah. I can see that. Okay, that's yeah. I've seen a couple of pediatric cardiac procedures, and wow, that's like the summum of skill and and heart. So.
Yeah.
Tell us a little bit about, in a more general way, what are some of the biggest challenges physicians face today, in your opinion, in adapting to new technologies?
Yes. So, as I was mentioning to you earlier, there's the medical mindset and culture is very different than the engineering mindset and culture.
Sure.
And I think one of the difficulties is that, a good doctor, you don't want your doctor to be creative. You want your doctor to have done this procedure they're about to do on you. You want them to have done it 1,000 times before and to do it exactly the same way. Engineers go into work every day and are doing something creative. They're trying to change something. They're trying to make it different. So doctors are by nature very, very conservative and very, very difficult to accept new technology, because their initial reaction to and I've gone through this many times, because when I've shown my device to doctors, they're always very skeptical until you show it to them and explain what it can do for them. But they resist new technology because they think, I'm doing it the way I'm practicing now is fine. I don't need any new gadgets to help me, be a better doctor. So, as I mentioned to you also earlier, to be able to get doctors to communicate with engineers is a very, very big issue that I'm very passionate about. Because, if a doctor can tell an engineer what their problem is, then the engineer can think about it and maybe come up with a solution for it.
Of course. Yeah, totally. Two different worlds. It's something which has changed in the curriculum now. You have the MD PhD programs, where I have seen many of my colleagues who actually did a PhD in engineering and a dual degree in medicine.
Yes.
So, trying to bridge that gap, and all of them I have seen in my experience have gone on to be successmal academics.
Yes. My younger cousin, although as we get older, the difference is not the same. But my cousin, little Stevie, who's not little anymore, is a brilliant MD PhD. He's got an MD, and he's a cardiologist, and his PhD is in physiology, I believe. And he studies calcium channel stuff, which I don't understand, but he's the head of electrophysiology at the University of Maryland, and he's exactly the kind of doctor who brings medicine into the new era, because he does a lot of consulting for electrophysiology engineering companies, because he really understands what the devices can do. So he I think he has some patents too on devices for doing like the maze procedure, which is how you get rid of atrial fibrillation by burning up some of the tissue around the pulmonary veins.
Yes, absolutely. I mean, cardiac electrophysiologist, it's a very well, you can't even get there as a cardiologist. You have to.
That's a whole other field of medicine. Everyone assumed, because I was an electrical engineer, that I'd want to become an electrophysiologist. But back in the day when I trained, electrophysiology was not automated very much, and it was very tedious. An EP procedure could take 6 hours, and I simply didn't have the patience for it.
Absolutely. This is, fascinating stuff. I wanted to actually be a bit more having our audience of, primary care providers and also specialists of different disciplines who would be interested to know about your experience. How do you see the challenges physicians are facing today on a more, I would say, existential standpoint? We talked a little bit before the show about how you had to actually exit the clinical, your clinical work, and focus on other things, just by the fact that those hurdles I would like you to expand on, and also talk about a bit of the regulation that you actually experience as a
Sure,
clinician.
sure. Well, so there are a number of issues that have a technical nature that have really impacted it. In my case, one of my reasons to leave clinical medicine was because the EHR, the electronic health record, is. This is an audience of mostly physicians, so I'm not telling you anything you don't know. The EHR is a real burden. It has not made our lives easier, and it provides an enormous amount of information stored on computers and in the cloud that is not accurate. And it creates a tremendous amount more work for doctors. So that's one big change that has really impacted practice. In my case, I was a solo practitioner, and so I didn't have any bargaining power with insurance companies, and then they just kept cutting my reimbursement to the point where we couldn't earn a living anymore. And I decided to exit medicine rather than to sell my practice. The other big hurdles really are the fact that doctors don't really own their practices anymore, and their time and how they use their time is dictated by administrators. They have a limited amount of time to spend with the patient. I mean, remember, my wife went to see her doctor, and at the end of the visit, she said, "Oh, by the way, I have this other problem," and the doctor said, "Don't even tell me about it. You have to make another appointment." So that's kind of playing. And again, this is an audience of mostly doctors. You know exactly what I'm talking about. If you work in a group practice or something where you have an administrator, your amount of time you can have with your patients is limited. And in my field, pediatric cardiology, I needed a lot of time. And if I was seeing a baby, I would allocate a full hour, and sometimes it would run over into a couple of hours because the baby would have to calm down enough for us to do an echocardiogram on them. And I would never let a patient leave until the parents fully understood, what was going on with their kid, and that could take a lot of time. So I don't think I would have done very well if I had an administrator, telling me I could only spend 15 minutes or a half hour with a patient.
That's this, unfortunately, the situation right now. This is tell us a bit about your clinic, how you had to actually decide to hang your stethoscope.
You mean why I decided to hang up my stethoscope? Well, it was a combination of several factors. One was the reimbursement, which is of course a very big one. We really couldn't make a living at it anymore in 2015. That was. Secondly was EHR. Now, as a pediatric specialist, I could have delayed using the EHR probably for a couple of years because my reimbursement wasn't dependent upon having an EHR, but it was inevitable. And then at that time, also, there was something new that came in. Again, if there's an audience of doctors, as ICD-10 was going to change everything. I was going to have to, retrain my office staff or get new people who were more computer savvy in order to use ICD-10.
That's the thing, I mean, I not too long ago, I found out how Epic was created, and how the first EMR came about was full flashcards. I might have said it in the last podcast. It is so fascinating. SOAP. It was supposed to distill things and make things very, down to the. This is also an art, if not a skill.
Well,
speak very concisely about what is like a big a brouhaha. Hence, what was a soap in 1993, 1992, around that time, became in 1997 where it was expanded to have the full review body system, and
we should have stuck with soap because soap was good. But if you look at an EHR now, very often you'll see the first thing will be the list of vaccinations the patient had when they were 10 years old. The next thing will be a bunch of lab results. You have to get into the middle before they even have chief complaint. And the doctors are so busy, they don't write a proper chief complaint. They just write, patient is doing well. I mean, I saw this all the time. So I like to tell people that I had the best electronic health record. What did I have? I had chief complaint, history of present illness, physical exam, laboratory data, impression, and plan, right? That's the way it would be. And that would be in a letter.
Logical.
And I developed, using Microsoft Word, I developed, shortcuts where I would have like, I'd say syncope colon, and syncope colon would be expanded into a whole explanation of how the patient should deal with syncope. So each letter was individualized, but those parts of the letters that were common, I could do with a single word and a backslash or something like that. Every patient had a folder with their ID number on it, and in the folder were all the letters that I ever dictated, all the cath reports and all that. So I like to say that was the best electronic health record ever, because it was on a computer. You could, if I wanted to know all my patients that had tetralogy of Fallot, I could just say search tetralogy of Fallot, and all of a sudden I would get all the patients who had TETs. And every letter of mine included the entire past medical history of the patient. So if they only had the most recent letter that I dictated and they showed up in an emergency room, that doctor would know exactly what the patient's problem was. But of course, we have this absolutely awful EHR, and I'm sure that they involved doctors very little in the development of that EHR, because it is absolutely classic engineering driven and not medicine driven. So this is something I feel pretty strongly about, obviously.
The value-based care initiative, based on, of course, the Affordable Care Act, actually puts a lot of emphasis on payments based on quality, and quality is basically patient outcomes. Yeah. And if you want to focus on just on patient outcomes, how are you going to be able to have good outcomes if you're not able to properly see the patients? Hence, technology, and we spoke about this also right before the show, if you want to comment on that, it was the trend, which is now still very, very happening, and it's only the beginning, is telemedicine and technology.
Yes.
Remote patient monitoring. We talked about, how you can actually measure a bunch of parameters with the patient at home, and connect with the patient at home. But then again, the doctor cannot do all this by himself. So the idea is to also leverage a bunch of individuals who are skilled in middle and lower care in order to drive those outcomes. Hence, technology can actually bring the kind of change. And I would like you to tell the audience a little bit of how, what advice do you have for physicians who might be maybe 10 years, behind you, and maybe 15 years behind you, how you as an expert in this interface of technology and medicine, what would you have done differently were 15 years ago? And let's say if you had that kind of time.
Well, I think there are many areas I can mention, but I would mention three areas. One is telemedicine, as we talked about before. I think telemedicine can become better, and as we talked about, I think that one way that telemedicine can become better is to provide patients at home with devices that are connected with their computers by Bluetooth, so that the doctor can get more useful information. They won't be able to touch the patient, which in some cases is necessary, but you can make a reasonable substitute for putting a stethoscope on a patient's chest, or getting an EKG or pulse oximetry or blood pressure or heart rate. That kind of stuff can be done with devices that are sent to the patient's home, and that can make for a much more effective telemedicine visit than just face-to-face communication. So I think telemedicine will mature, and it is definitely becoming better. My business partner runs a telemedicine company that is a real niche, is for emergency medical services, and he is the largest provider of ambulance to hospital telemetry equipment, so that the doctor in the ER can provide urgent care on the field. He can give instructions about, he can make judgments, and then give instructions about, for example, giving IV fluids or volume or whatever is necessary for a patient, or treating a heart attack, telling them to give them an anticoagulant or something like that before they get to the hospital. So telemedicine, number one. Number two, and maybe number one, I think, is AI. I think AI is going to radically change medicine, because, we have a limited capacity for storing information in our brains, and we have a good sixth sense. So I think a partnership between a doctor who has a lot of experience and a lot of good feeling for his patient and AI is potentially revolutionary, because if you want to get a differential diagnosis, AI is going to get to the point where it's going to make the diagnosis that you're going to miss sometimes. You tell all the symptoms the patients have, all their laboratory data, their vital signs, and I think AI is going to be explosive. It's not going to replace doctors, but I think it's going to be it's going to be like having a brilliant physician's assistant in your room with you. And I would definitely encourage doctors, primary care doctors, to investigate, to look into AI. And undoubtedly, there will be products that will come out that will be targeting the medical profession. In fact, that's something I would love to work on. I think that is potentially great. And then I think a third area, and the area which is very dear to my heart, is new ways of monitoring patients. And as I had mentioned earlier, I developed a device for early detection of hemorrhagic shock. And this is a device that can be sent home with a patient after they had surgery, and if they have internal bleeding, we'll be able to detect the decrease in blood flow that occurs in their extremities when they lose a significant amount of blood, so they can get urgent care if necessary. It also is a platform technology and may be useful in heart failure patients, because heart failure patients, as you probably know, have a high readmission rate, and there's penalty if the patient is readmitted for heart failure to the hospital within, I think, a couple of weeks. The hospital won't get reimbursed. So if we can send a patient home with this device that will detect the decrease in peripheral blood flow that occurs with heart failure, that may be a warning sign that will get them back to the hospital early. We don't have clinical trials in that area yet, but we think that's a promising application for our technology. So those are the areas that I think are of greatest interest to me in terms of new technology and medicine, particularly primary care medicine.
Tell the audience a little bit of how you can be of help to them if they need guidance or consulting or that sort of thing.
Oh, well, thank you for asking that. So, I speak doctor and I speak engineer. So I can communicate very well between these two worlds. And I'm very interested in commercialization of new medical technology. So I provide advice through my company, which is called Medical Invention Consulting, to doctors. I've had some clients who are doctors. One was an anesthesiologist who had an idea for a new type of port for delivering drugs. To doctors who are inventors. Also, sometimes, you'll just get a very smart person who's got a relative in the hospital, and while they're in the hospital, they'll see something about the hospital bed that they think they can make an improvement on, that kind of thing. So to inventors, investors who are doing due diligence, they want to know, whether or not the product that they're being presented with, the startup company, has something that really, is a solution in search of a problem, or is it really something that solves a problem? And, I do that by calling doctors in the specialty. One of them was a very interesting one. It was an anesthesia project. And it was someone who came up with a new type of stylet that lit up on the throat. But then when I called my anesthesiology friends, they told me that they use direct visualization with fiber optic cameras, and they don't use stylets anymore. And so I told that to the academic institution that was thinking of patenting and commercializing that, so they wouldn't waste their money, because patents are very expensive. And I also provide advice to, so I say academic institutions, inventors. Oh, academic institutions, I mentioned, investors, and then corporations. So I did a bunch of work for Datascope, which is no longer a Datascope. It was bought out by a Japanese company, but in helping them design their user interface for doctors and nurses, because I like to often say that engineers are menu driven, and doctors and nurses are holistic driven. So, if you have to go 5 steps down into a menu in order to change a parameter on a patient monitor, it's never going to get used by a medical person. So I try and keep the menus shallow, that sort of thing. Or actually, they sent me out to the West Coast. They were thinking of buying a company that had an external defibrillator for use in the hospital. And, I went through this all this stuff. And I just said to them, you're missing the most basic thing. You can't shock patients who are awake sitting in a hospital bed. They're going to be sitting there terrified of this device. So I would advise against buying this company. So that was an example of a solution looking for a problem, really.
I see. Of course, I like that how you phrase it. But
yeah,
and I think your experience is really unique that you have that engineering experience and the medical experience. I think the challenges of technology and of regulation will be here for a long time. And going back to the electronic health record, I hope if AI can actually bring that wall down, which is the EHR, and make things more clinical and more patient oriented and more human. I think that is the goal of technology, to be useful. That will be a game changer, and I think we have a real chance here. So
is it okay for me to mention the contact information for my consulting?
Go ahead. We are wrapping up, so please go ahead.
Yeah, so my website is www.medicalinventionconsulting.com. My phone number is 908-347-2662. And my email is lmarks, LMARKS, @MGI, M like Michael, G like George, I like ice cream, MGImedical.com, or Marks NJ, that's my last name, MARKS, NJ like New Jersey, @EROLS, Errols.com.
Awesome. Thank you so much.
Thank you so much for inviting me. This has been a very stimulating conversation. I really appreciate it.
And we look forward to keep talking. Next week we'll be talking about sleep. So you'll be in the audience, but I would love to have you again in the future, Dr. Marks.
Okay, great. Absolutely great. Thank you so much. This has been fun.
Absolutely. Thank you. Thank you, guys. Have a good
Take care, Dr. J. All right.
Hey, we actually just.
Oh, you're back. Yeah, I wasn't expecting you to disappear. That was really fun.